Good morning, thank you. So I am here to report about our beginning experience. So how do you go on? Sorry, is it? No, thanks. Why is it important to know where the cortico-spinal tract is? Because the third vertical is very variable in amplitude, and this may change the position of the cortico-spinal tract, and we want to avoid side effects. So usually it is proposed to use the tractography to locate the cortico-spinal tract, but depending on the operator and the algorithms, you have very different results, and it's also prone to distortion, while inversion recovery may show the structure without these problems. This is the common result that you can obtain. These two bright spots here are the cortico-spinal tract. We'll see afterwards why. So what does it allow? It allows the visualization of the cortico-spinal tract and the relationships with the other structures with no need for post-processing. So this is a result in the post-operative phase. If we perform a Weigert coloration staining of the posterior capsula, we won't see great differences inside it. But we know that sometimes in normal T2 images we see a faint hyperintensity in the posterior three-quarter of the cortical of the posterior internal capsule. This is because there are very big neurons, axons, in this region, which are 3 or 4 times bigger than other axons in the internal capsule. And the curious thing is that if we go to perform a silver staining of the internal capsule, which is specific for the axons, we can see only sparse axons in the region of the cortico-spinal tract, normal T2. And the reason why we see such low staining is that the axons are very big, they're fast conducting, but they're very sparse. So we have less axons than in the other regions. Well, with the inversion recovery, we can see this bright spot, which is the region with less axons and with more interstitial fluid between the axons. So what did we do? We had just 8 patients when we performed this study. We acquired the 3-dimensional inversion recovery technique with the 1.3 thickness, and we also acquired other studies. This was done to depict the position of the cortico-spinal tract and to isolate it from other structures surrounding it. So we found out that we could demonstrate the position of the cortico-spinal tract in all the patients, and we could distinguish it from the thalamus, which was slightly hyperintense to the internal capsule, and we found out that there was a variable degree of hyperintensity of the thalamus. In the postoperative phase, there was the cortico-spinal tract was still clearly visible in all but 2 patients where edema invaded the internal capsule. So this was a preoperative stage, and here you can see that the edema borders the internal capsule, and there is a faint hyperintensity of the cortico-spinal tract, which is involved from this edema. Another case, in this case, the edema already 24 hours after the treatment invades the whole posterior limb of the internal capsule, and we can't distinguish the cortico-spinal tract. This patient developed weakness 3 or 4 days after the treatment. Another case here, there wasn't a significant edema, and you still can distinguish the lesion from the cortico-spinal tract. So we use this technique during the planning to verify the distance from the third ventricle border to the cortico-spinal tract. What did we came out with? Three-dimensional inversion recovery helps finding the cortico-spinal tract in each patient, and it may help avoiding and predicting weakness in the arm. And of course we need further experience to verify our findings. Thanks to all the group that performs the treatments in Verona. Thank you very much for the attention.
Thanks very much. Questions?
So are you only consider the target based on the imaging findings?
Yes, we are considering it. We use it in the pre-planning phase just to understand how far the cortico-spinal tract may be from the lateral border of the third ventricle. Then we go to the T1 imaging, but we already know which will be our lateral coordinate.
What if the patient didn't show the improvements in there? And if you are touching the right target, so you are moving to the other areas, which direction you are usually moving?
If we don't find an improvement, we usually
there's
move,
no improvements with your best target,
we usually move medially, not laterally. Yes, but in this way, anyway, we choose the most lateral target at the beginning that we would feel safe, considering the position of the cortical.
How far you move from the border of the internal capsule to the midline?
Not always 11 millimeters, which is the common distance considered. If the patient has a very wide third ventricle, then we go down to 10 millimeters. 9.5, depending also on where we find the cortico-spinal tract in these images.
Okay, thank you very much.
Thank you.